Hello and welcome to KCS Connects. I'm Jack Miller, one of the co-directors of Key Clinical Skills. KCS Connects is our way of helping connect you with some literature and clinical pearls that we believe will positively impact on your clinical practice. This week, we're going to look at something different. Instead of doing our usual literature review, we're going to give you a clinical pearl, and this has to do with the lateral shift. And as you can see in the picture over there on your right-hand side, things look a little bit funky there, don't they? So the lateral shift is often associated with acute episodes of low back pain. There may also be referred buttock and or leg pain as well. The important point here, and we'll discuss this more in a few moments, is that this is a lateral translation of the hips under the shoulders, possibly also the shoulders on top of the hips, or a combination of these two. And it is hypothesized to be disc related, but at this point, we're still not quite sure. Now, the prevalence of this is dependent on the literature you look at. In the New Zealand studies, 25%, USA ranging between 12.5 up to 36%, United Kingdom 5 and about a half, and in Finland, something interesting going on there, up to 56%. Also about the prognosis. The original paper describing this was by Porter and Miller back in 1986. And they took a medical view of this problem, and they've described that this is associated with a poor prognosis for conservative management. Now, the physiotherapy perspective on this is quite different, as espoused by Robin McKenzie in 1981, where he stated that 90% of these cases are rapidly reducible, particularly if the shift is contralateral. So let's talk a little bit about that idea of contralateral versus ipsilateral, because it is quite important in our prognosis and how we're going to manage these patients. There's different types of nomenclature. First of all, this idea of a contralateral shift, and this is certainly the most common and does have a good prognosis. You can see there in figure number 1, the shoulders have moved away from the side of pain. Ipsilateral shift is the opposite, shoulders moving towards the painful side. Now, this is actually relatively rare, thankfully, because they are much more difficult to manage at a conservative level. There's also something really interesting, and I've seen several cases of these over my career, and that is the alternating shift. The patient presents with a left shift, you correct them, you get them nice and straight, and they suddenly flop over to a right shift or vice versa. It's almost like they're on a ball bearing. And there's something else we should consider, and that is what was some described as a functional shift. When you look at the patient, they look nice and straight. However, they can side glide one direction without problems, no pain, and it's quite easy to have them move that direction. But they're actually quite obstructed and blocked moving the other way. So they are shifted, you just don't see it. Now, an important point here about lateral shifts versus side bending. If you have a look at the picture over on your left-hand side, you see that the individual's trunk has moved laterally, but the shoulders have stayed relatively parallel to the hips, haven't they? Now, let's contrast that to the picture over on your right, where the pelvis is level, but now the shoulders are quite oblique. A little tip here at a clinical level is don't look at their back, look at the hand. If you look at this individual with the lateral shift on your left, the hand is away from the body on the side of the shift. However, with side bending, it's the opposite. The hand moves away from the body on the opposite side. So that can give you a good idea whether or not it's a structural scoliosis versus a true lateral shift. Now, the differentiation between these two is quite important. And if you have a look at these x-rays, and this is from a study by Oakley in 2018, on your left-hand side is a AP view of a lumbar spine with an individual with a lateral shift. Now, if you contrast that to a structural scoliosis over on your right side, you can see that these two types of deviations are quite different, aren't they? Now, why does this come about? Well, the answer is we're not sure. It once was hypothesized that it had to do with the individual escaping pressure on the irritated nerve root. If the herniation of the disc was on the deltoid of the nerve root, as seen on the left image over there on the right, then the individual would deviate away from the side of pain to try to relieve pressure. If, however, it was in the axilla of the nerve root, then they would deviate towards. However, this has actually not been shown to be true. And again, we do have this idea that individuals can have this alternating shift. So again, this model doesn't really fit too well with that, does it? In assessing the lateral shift, some tips here. First of all, stabilize the shoulders and then translate the pelvis underneath the stable shoulders. Try to make sure you don't side bend by holding that shoulder down. Evaluate the ease of movement, range, and the effect of repetition on pain location, as well as the range and ease of movement. If the individual does seem to present with a lateral shift, strong encouragement is to deal with that lateral shift component before you deal with the sagittal plane. There is the standing manual correction as described by Mackenzie, and this is where the person is first of all in weight bearing. Why? Because it's a weight bearing phenomenon. It doesn't exist if you hang the person from a bar or you put them in water in a pool. It disappears. It only presents if the individual is in weight bearing, so it needs to be treated in weight bearing. Stabilize the shoulders and draw that pelvis underneath. Don't try to hold this pelvis and push the shoulders. Make sure that it's side gliding that you're performing, not side bending. Keep those shoulders level. And a little bit of a tip here, because I've had this happen to me. Have the patient have a hand on the bed and place a chair behind them. Why? Because they can have a vasovagal response and faint. If you've done that manual correction, then it's important to have the patient do their own self-correction as well. Little tip here is have a towel, rolled up towel between the shoulder and the wall. Keep the shoulders level and glide those hips underneath. Another little tip is to have the patient's foot right up against the wall so they do side gliding, not side bending. Now, if you'd like to learn more about the lateral shift phenomenon and its management, come visit us at www.keyclinskills.ca, where we have our modern MSK low back pain program. It's self-paced, 8 units, distance learning, and has over 100-page handouts for you to be able to keep as a reference. Hope it's helpful to you in your clinical practice. Thanks for your time and attention.